present here. We are gathered here today for our 12th PTCR, that is physiotherapy combined now. At the last PTCR, our emeritus chairperson sir guided us and advised us to work with a case, like to present a case where both the departments, like the orthopedic or the neurological department, multidisciplinary, both the departments in which we are collaborating will work on a case and we'll see how the recovery of the patient is being approached by the combined effort of the disciplines, different disciplines of medicine. So today we are gathered here to work and talk on a case which has been a 37-year-old male with multiple fractures of right upper lip as well as lower knee. So with us, we have with us Dr. Aditi Vijayvargiya, Professor, Department of Orthopaedics, Dr. Vivek, Sir, Assistant Professor, Department of Orthopaedics, Dr. Rohit Tyagi, PG third year resident, Department of Orthopaedics, and also with us we have a speaker from our department, Dr. Riya Sharma, Assistant Professor, MGPC, and Dr. Aditi Vijayvargiya, PG resident, MGPC. We'll all be talking today about this case and we'll see the work done by the orthopedics department and the work done by the physiotherapy department to bring out the best possible treatment for this patient. So we'll first start with Dr. Rohit Tyagi sir and Dr. Vivek Bhambhu sir, who will help us and assess the patient and tell us about the...
So good afternoon everyone, respected dignitaries, faculties and my dear colleagues. I am Dr. Rohit Tyagi from the Department of Orthopaedics to present a case of a 37-year-old male with multiple fractures of upper and lower limb. So a 37-year-old male presented in our emergency with history of road traffic accident in Hanumangarh, Rajasthan at around 2 p.m. at the same day. Patient was primarily managed at the nearby local government hospital and then was referred to a higher center. As it was a case of multiple fractures and could be a polytrauma, so initial management was done according to the ATLS protocol. Patient was vitally stable with GCS of 15. According to the ATLS protocol, the primary survey was done. And circulation was managed and there was no neurological impairment present. In secondary survey, a detailed history was taken along with the head-to-toe examination. After thorough history taking and examination, we went with the required investigations. So on secondary examination, we found multiple abrasions were present at the various body parts. There was pain, swelling with deformity at the right elbow. There was pain, swelling, deformity with grade 3B injury according to the Gustavus-Anderson classification in the right hand and wrist joint. As you can see in this clinical picture, there was pain, swelling with grade 1 injury in the right knee. This can be appreciated in this clinical picture. Puncture wound is present over the right knee. And in right lumbar region, we had a huge discoloration of the skin with localized palpable swelling, which was a moral elevation. So we went with the radiological and the blood investigation. Coming to the radiological investigation, this was the X-ray of the patient of the knee. This is the AP view and this is the lateral view. We can appreciate the distal end of the femur, proximal end of tibia and fibula. In the AP view, we can appreciate the lateral condyle fracture. In the lateral view, we can see that this fracture has a coronal split. So any intra-articular lateral condylar fracture of the distal humerus with coronal split is known as Hoffa's fracture. And to further classify it, it is a type 3. Coming to the basic of the Hoffa's fracture classification, according to the Lederman classification, he has grossly divided this fracture into 3 types. In type 1, the fracture line is parallel to the posterior cortex of the femur. In type 2, the fracture line is parallel to the base of the condyle, and which is further divided into A, B and C. In type 3, the fracture line is oblique. Now, this is the X-ray of the right elbow of the patient. This is the AP view, this is the lateral view. We can appreciate the distal end of the humerus, the distal end, the proximal end of the radius ulna along with the shaft. Here we can see there is a coronal split in the distal humerus, which was classified as intra-articular distal humerus fracture, and to further classify this fracture, it was a type C3 fracture. Coming to the AO classification of the distal humerus fracture, that has been grossly divided into three. The first is the extra-articular, the partial articular, and complete articular. In partial articular, there is only involvement of a single condyle. In complete articular, we have C1. In C1, there is a simple fracture pattern along with both the condyles split. In type C2, C1 is present along with the metaphyseal combination. In C3, there will be no metaphyseal combination, but epiphyseal combination will be present. So, our fracture was C3. Coming to the X-ray of the right hand, this is the AP view and this is the oblique view. Here we can see there is in the oblique view we can appreciate there is subluxation of the first metacarpophalangeal joint along with the fracture of the base of the second metacarp. The blood investigations, all the parameters were under normal results except the hemoglobin, which was 7.3 grams per deciliter. So we had a diagnosis of a 37-year-old male with history of road traffic accident with a grade 1 open right knee MOFAS type 2 type 3 fracture, right distal humerus intra-articular type C3 fracture, grade 3 open right subluxation of first metacarpophalangeal joint with fracture of the base of second metacarpal and a moral lesion in the lumbar region. To proceed with the management, I would like to call Dr. Vivek sir.
We have a significant blood loss to explain the hemoglobin of 7.
Yes, sir. Because patient has moral lesion at lumbar level. We have read that lumbar lesion and we are approximate around 750 ml of blood. That is to be the most important part.
Is there any image of that? We can do any
Image of
So basically, what we need to tell the students that an internal injury of a major pelvis, eye, spinal region, you can have significant blood loss without any external blood loss.
Good afternoon, everyone. I am Dr. Vivek. I am taking part in management in OER. So basically, for this type of patients, we have to approach this type of patients with multidisciplinary team approach. So as you can see, the orthopedician usually take the management of the fracture. The plastic surgeon, they used to approach the open wound, which is present in this patient. And the most important part, which we usually don't consider in our practice, but in this type of patient, we always need to include for management of post-operative rehabilitation, physiotherapy. So for the fracture of distal femur, we approach through anterolateral approach of distal femur. We have taken the anterolateral approach, we have lifted the quadriceps and we have applied the plate, anti-flight plate and 62 as you see in this image. Anti-glide plate, this is screw fixation and it was a stable fixation. And we also train the lumbar moral lesion. For upper limb fracture, we have chosen the para-triceps approach. We have lifted the triceps muscles and we have applied dual plate. One is on medial side and other is on posterolateral. And the fixation was very stable. And we have also fixed the fracture and dislocation of hand. And the plastic surgery opinion was taken. And according to them, they advise daily dressing for next 2 weeks. And after that, they will do the skin graft. So the main thing is that is surgery is end of the treatment. So basically, in orthopedics, we have one word which we used to say fracture disease. Fracture disease means the time intervention, the pre-operative, post-operative, or the peri-operative time. because of the fracture, patient has many complications. It can be lead to like musculoskeletal involvement, muscle weakness, atrophy, soft tissue contracture, joint stiffness, osteoporosis, and in severe cases, it could be DVT due to immobilization, pulmonary embolism, or orthostatic hypotension or chest infection. To prevent this, the physiotherapy is must. There are ample of literature available, like stiffness is most common sequel after open reduction of internal fixation of humerus fracture or knee injury. And many times we have seen in the OPD, the patient comes to us with after several months of surgery, and they used to say that the operation was done, but still movement is not there. So this problem always happens when you not include the physiotherapy team in your team approach. So, and it's also due to stiffness in perioperative, post-operative fracture through the adjacent joint also. Like if you are treating the knee fracture, but you can see the stiffness near about the joint of hip and ankle is present. So it is always, we are treating the patient, not only the fracture. Now,
the session is always open for questions. If any one of the students, MPTs or PPTs, have any questions regarding the surgery or the general assessment or how the patient or the classification, can ask the questions. After which we move towards the physiotherapy aspect of today's session, where we will discuss the general assessment as well as the physiotherapy management that has to be done as physiotherapists when a case is being referred to you by the orthopedicians after like post-operative in this scenario, a post-operative case that has been referred to us. Any questions from the student side? Or shall I move forward towards the physiotherapeutical assessment, post-operative general assessment, and the anatomical considerations that are there? For which I would like to request Dr. Riya Sharma, Assistant Professor here at Mahatma Gandhi Physiotherapy College, and she will be telling us about the general assessment of these patients.
Do the physiotherapy students attend these BLS and ABLS courses?
Yes, sir.
Is it compulsory for compulsory?
BLS is compulsory.
BLS for all?
Sir, it's for like pass out students, like PPT final year and MPT final year. BLS is compulsory.
And what about ABLS?
Sir, ABLS is not there.
Do you think it will be useful to them? For the physiotherapy students? At least the postgraduates? So see, what I said earlier also, for us you are a physiotherapist, for an outsider, for a layperson you are a doctor. So suppose there is a trauma, I think at least the postgraduates, that's my personal opinion, that you are a better judge, and let the physiotherapy faculty discuss this in your faculty meeting, in your college, whether, if not mandatory, whether we should encourage them at least, because the problem is it involves payment of the fee also. But I think all postgraduates preferably should attend PTLS.
Good morning, everyone. So now I will discuss about the post-operative general assessment and anatomical consideration. So begins with a quick overview of the patient demographic data. This is the patient demographic data. A case involving 37 years old male, Mr. Subhash, who suffered multiple fractures due to road traffic accident on August 21, 2024. We initiated his PT management, PT rehabilitation on August 29, 8 days after incident, and in the chief complaint, the patient presented with swelling around the elbow and pain in the hand and forearm due to laceration and the restricted movements in the elbow and knee. So, in the history of the patient, that is resulted from a sudden road traffic accident. Also, the patient has a history of smoking, tobacco use, dust allergy, and index finger fractures occurred in 2017. In the physical examination, Mr. Subhash has a mesomorphic body type that is characterized by a moderate muscular build, a balanced bone structure. This can be beneficial for his rehabilitation process, and as it may support faster recovery Also on examination, the patient present with a visible bandages, scars and plasters cast on hand and forearm, support with sling to immobilize the affected area. The patient is conscious, oriented and cooperated during the assessment part. The patient is on bed rest and is not permitted to ambulate for first 6 weeks due to the post-operation fracture, the immobilization phase with a brace, and the patient presents a slight head tilt and noticeable shoulder drooping during the posture assessment. In the tenderness assessment, there is a grade 2 present in the elbow and knee, indication moderate pain, but in the forearm and hand, it is graded as 4, reflecting the extreme pain that significantly limit the functions. Swelling is present around elbow and slightly is observed in the ankle. He reports sharp and throbbing pain in the hand and forearm, which intensify the movements or any pressure applied to the affected area. So there is a BAS scale I use to check the pain intensity and the global numerical rating scale. So for the hand and forearm, the patient reports severe pain that is related to 7 on both VAS and VNRS. In the knee and elbow, the patient is moderate pain but aggravate to severe during passive range of motion exercises. In the radiological finding X-ray, there is an intra-articular distal humerus fracture, lateral condylofemoral fracture, and fracture at the base of the second metacarpal. There is a subluxation of the first metacarpophalangeal joint. So moving forward to the anatomy part of the affected area, starting with the intra-articular distal humerus fracture. So in the anatomical structure involved, there is a trochlea and capitulum are the key components of the distal humerus that form the articular surface of the elbow joint, and in this medial and lateral condyle with ulnar collateral ligament and lateral collateral ligament and annular ligament is also involved. Muscles affected: brachialis, triceps brachii, biceps brachii, and pronator teres and pronator quadratus is mainly for supinator muscles that are also affected, and conius muscles that is mainly assist in elbow stabilization and for extensors that is also affected, and indirectly the muscles affected that is forearm flexors and extensors, muscles like flexors carpi radialis and the extensors carpi radialis. Rotator cuff muscles will also be compensated due to prolonged immobilization at the elbow. This is the neurovascular structure. So in this, the brachial artery is commonly affected. Radial and medial nerve is also affected. The use of a sling and a heavy plaster on forearm and hand place additionally stress on the shoulder, and this leading to alter movement patterns and shoulder discomfort in this deltoid and rotator cuff muscles and trapezius, pectoralis majors, minors and biceps brachialis are also affected. This is the normal X-ray. extension, right? So, sorry, flexions, right? So biceps femoris, semitendinous, membranous muscles are affected in this, and in the ligaments, there is a lateral collateral and medial collateral ligaments are affected. So there is a gastrocnemius muscles that assist in the knee flexion and ankle plantar flexion that is also affected. In this neurovascular structure, there is a popliteal artery and common peroneal nerve affected, and since the knee is immobilized, the patient is on bed rest and the hip compensate for changes in weight distribution and movement patterns, which leads to strain or discomfort. Also, like the movement can impact the ankle mechanics. So the patient has a limited range of motion in the elbow due to begin in the immobilization phase at 90 degree of flexion on day when the muscle strength is minimal with MMT grade 1 indicating only a flicker of contraction and visible muscle contraction. The presence of plaster aids extra weight restriction movement on both elbow and shoulder, and for the knee, the patient was immobilized in a brace at 0 degree of extension, and after removing the brace, knee is flexed up to 5 degrees only achieved with passive support, showing significant limitation in movement. So moving forward to the short-term goals and long-term goals, there is a management of pain, control swelling and inflammation, maintain range of motion and prevent stiffness, prevent muscle atrophy, protect surgical site, promote circulation, and last, prevent complication. In the long-term goals, after 6 weeks, achieve full range of motion, improve strength, restore functional mobility, enhance proprioception and balance, prevent re-injury, achieve independence in ADLS, and minimize scar tissue and increase soft tissue mobility, enhance overall fitness and endurance.
Thank you, Dr. Riya. It is important to understand that after the referral from the orthopedicians or orthopedic department, it is important for us also to take a proper assessment, a thorough assessment, so that we can understand what is required and what to be followed as our treatment protocol, where we create our short-term as well as long-term goals. Now, also why Dr. Riya explained the anatomical point of view was because as physiotherapists, it is our basic role to understand which muscles are being affected and on which muscles we need to work throughout our protocol to make sure that there is not a single compromise at any point. Sometimes we try and we forget about the small muscles that are there, like in coneus, which will not, if we don't work on it, it will not help us achieve the complete extension range. And if you are not working on brachialis or brachioradialis in every different aspect, there will be a limited strength of the patient. So now we move forward towards the physiotherapy management, and for understanding this, we have Dr. Aditi Vijayvargiya, PG resident, and she will be explaining what physiotherapeutic management we gave to this patient till the time he was here with us.
Good afternoon, everyone. My name is Dr. Aditi Vijayvargiya, and I'm a first year PG resident. I'll be discussing with you all the day-wise PD management which we have done for the patient. So starting off, the interventions done on the post-operative day first and second. So the first thing we need to approach is the systemic approach, which means that apart from the elbow or the upper extremity and the lower extremity, what all functions are compromised in the patient. So most commonly the cardiopulmonary is the deep breathing exercise. The second one is the diaphragmatic breathing. Diaphragmatic breathing comprises of simply inhaling through the nose and exhaling through the mouth. Apart from it, keeping one hand on the chest and one hand on the abdomen. This simply activates the tactile stimulation in the patient, which also improves the respiratory pattern, the pulmonary expansion, the chest expansion of the patient. It also reduces the work of breathing, the dyspnea, and also it reduces the chances of atelectasis that will go after even the patient gets discharged from the hospital. Now, third one is the pursed lip breathing. What is the pursed lip breathing? Simply inhaling through the nose and exhaling through the mouth in the form of a whistle, right? This simply induces relaxation in the patient. Now, as there is some physical disability in the patient, but there is also mental disability that the injury has caused to the patient. So, relaxation is also a must we need to include in the treatment. Now, fourth is the segmental breathing. As all of us know that it is a multi-injury patient. So, the patient is immobilized for prolonged periods in the supine lying position, which simply indicates that the posterior and the posterior lobes of the lungs would be affected, for which we are going to give the segmental breathing. We can also see in the video that how is the patient doing the deep breathing exercises. The therapist commands to the patient to simply inhale and exhale. Now moving on to the upper extremity. Upper extremity includes, the treatment includes two basic type of exercises which we are going to follow the first and the second day. The first one is the passive range of motion of the elbow and the shoulder. Why? This elbow is the joint which is primarily affected and shoulder is the joint which is secondary affected. So passive range of motion includes the flexion and extension of the elbow. And of the shoulder, we are going to start with flexion, extension, abduction, adduction, and the rotations of the shoulder. Now, all these passive range of motions will be performed in the pain-free range, only till the limit that the patient is able to tolerate. Now, moving on to the isometrics. Why are we using isometrics here? Because not only is the range of motion affected, but due to the injury, the strength of the muscles is also compromised. And because the patient is immobilized, we do not want any movement to occur at the injured site. So we are going with the isometric exercises, which will help strengthen the muscles around the elbows and the shoulder even without movement of the joints, still gaining the strength. So as we can see in the picture also. Now coming to the lower extremity. The first thing is that the limb is kept in elevation. Now ankle pumps, passive knee flexion within the pain-free range and calf stretching. Now, ankle pumps are the exercises which simply help to maintain the proper circulation in the lower extremity. It also reduces the chances of DVT. Now, ankle pumps can be performed both either the leg is kept in elevation or even without elevation. Then, moving on to the passive knee flexion within the pain-free range. Again, because it is just post-operative day first and second, so we are not going to go in the painful ranges. So, only performing in the pain-free range. Now, as you can see in the video also that ankle pumps are performed by the patient actively. Secondly, the calf stretching. Calf stretching also helps to maintain the mobility of the muscle. Now, whenever we are going for stretching of any muscle, it is simply going to maintain the blood circulation in the muscles, which will promote healing of the tissue surrounding the injured site. Now, coming to the post-operative day 3rd and 4th, starting off with the upper extremity. Now, also we have to keep in mind that the breathing exercises have to be continued at least 2 to 3 or 4 times per day by the patient, which is done by the patient actively. So now coming to the upper extremity, again we are going to continue the passive range of motion and the isometrics. But now the passive range of motion, the ranges have been improved. Whatever we have achieved in the post-operative day 1st and 2nd, we are going to achieve that and also go beyond that. Secondly, even with the isometrics, we are going to improve the holding time of the isometrics. For example, if we have started with 5 seconds hold, now we can go up to 10 to 12 seconds hold in the isometrics. Apart from it, because the patient has got unrestricted shoulder mobility, so we are also going to start with the active assisted range of motion of elbow and the shoulder. But due to the weight of the plaster that has been put up on the wrist, we are simply going to assist the patient with the weight of the plaster, and then the patient can perform all the active ranges. Now coming to the lower extremity. Again, we are going to continue with the ankle pumps. The knee flexion ranges would be improved as much as the patient is able to tolerate. The third is the hamstring isometrics. Now, hamstrings and quadriceps are the major muscles that are present around the knee. Hamstrings are used for the flexion and the quadriceps are used for the complete knee extension. Now, because the patient's limb is already immobilized in 0-degree extension, which means that the hamstrings are already intact. So, again, hamstrings isometric, so that even after we remove the braces or even after the patient is discharged, the weakness present in the hamstrings and the quadriceps does not interfere with all the ranges. So, hamstrings isometric, quadriceps isometrics done, and then also range of motion of the hip, because hip is the adjacent joint. So, adduction and abduction. We can also see how is the hip abduction and adduction is performed. And also the second video, it shows how can be the quadriceps isometrics be done. Now coming on to the post-operative day 5 and 6. Again, starting with the upper extremity. The first thing is progressive passive range of motion, again of the flexion and extension of the elbow as we were doing, but again improving the ranges. Secondly, active assistant range of motion of the shoulder that was already continued. Now also we will try to add the circumduction in the horizontal plane as much as the patient is able to do. As you can also see in the videos. Like in this video, the patient is trying to isometrically go into the external rotation. Now secondly, the patient is going into extension. Now here we need to keep in mind that the weight of the plaster is so much that we have to give assistance to the patient. And in the third one, we can see that the patient is able to actively circumdate the shoulder. Now coming to the lower extremity. Again, the progressive knee flexion and extension has to be continued. Secondly, the knee extension and flexion in the sides, as you can see in the photos. Now, active assisted SLR. Okay, so this video was the active extension which is done by the patient. In the second video, we can see that the patient is taking the limb into SLR, which is again assisted by the therapist. And also, we will go with the hamstrings stretches. Now, post-operative day 7 and 8. Again, for the upper extremity, we are going to continue the whole rehab program that we have done so far. Also, we will add the glides. That is the grade 2 glide, in which grade 2 glide is mainly used to reduce the pain and also somewhat prepare the patient for the upcoming mobilizations and upcoming ranges we are going to achieve. Now again, continue the program mentioned earlier. Now we can see in the videos also that there is shoulder range of motion also, which is active and assistedly performed. Now coming on to the lower extremity. Again, the knee bending or the knee flexion has to be continued. With this, we are going to add the patellar mobilization also, which will improve the range of motion of the knee extension and flexion. Secondly, we have got the tibio-femoral mobilization also. Again, all these mobilizations, even in the elbow or even in the lower extremity, we are only going to go with the grade 2, which means we are not going to go in the painful ranges. Now, we have also got the sitting marching. So these are the patellar mobilizations. And in the photo, we can see that with the help of the unaffected limb, that is the left leg, the patient will go for flexion ranges. Now, the ranges we have achieved at the time of discharge. Now, firstly, we will see that the unaffected side, active range of motion is completely normal. That is, extension and flexion both are complete ranges. Also for the knee, we have got complete ranges of the patient. But when we come to the right hand side, so the active range of motion in extension was only 30 degrees, whereas I'm really sorry, the ranges are written interchanged actually. The passive range of motion is 30 degrees, while the active done by the patient is 20 degrees. Now going for the flexion, the active range of motion is again 100 degrees. Why? Because already the elbow was there immobilized in 90 degrees. So now we have come up to the 10 degrees more. And then also 105 degrees passively. Going for the knee, the patient already has got the limb immobilized in 0-degree extension, so the ranges remain 0 degrees. But for the flexion, the active range is 50 degrees, and with passive, we have got 55 degrees. Now the muscle power also we have seen that on the left side, everything is normal, which is 5. And going for the right hand side, the day when the patient came to us, it was 1, grade 1 of the MFT, and now we have got 1 plus. Also in the knee, the extensors are 3. As we could see in the image also, that the patient was actively extending the knee. Now coming to the home program, as soon as the patient is discharged, what does the patient need to do? So first thing is that physiotherapy treatment has to be continued by the patient. Now, secondly, continue the elbow flexion and extension actively. Why? Because elbow has got major 2 actions under the flexion and extension. So we are going to continue with that. Elbow, shoulder, all the range of motions, the knee range of motions we have to continue. Secondly, the breathing exercises at least twice daily the patient should perform. Next, we come to the hot and cold pack. Now, hot pack can be applied before the physiotherapy treatment so that it reduces the stiffness and helps to increase the range of motion. And secondly, after the treatment gets over, we can apply for the cold pack. Now, coming to the progression of exercises, although this is actually this is indicated by the physiotherapist whomsoever the patient is seeking. But then PRE, that is progression of exercises with the help of resistance exercise, we are going to improve the stamina and the strength of the muscles. And lastly, that is educate the patient about the operated part. For example, not doing any massage over the fracture side, also not lifting any heavy weights or not trying to work excessively. So these are also majorly wound care or the dressing care has to be explained to the patient. Now, complications of unsupervised rehab. If the patient is unable to seek the continuous physical therapy treatment, what all can we see? Now, stiffness in the affected and the adjacent joints, for example, elbow is affected, but shoulder stiffness can also be present. Second is the contractures. Third is the wasting of muscle or the muscle tone has been reduced. Nextly, if the patient does not take care of the injured side properly, then also re-injury chances can be present. Then, pain exaggeration. The conclusion of all this rehab which we have done is simply that physiotherapy is extremely important when it comes to the rehab of the patient, especially in the fractures. Now, thank you so much.